Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. Today, I'm unpacking the landscape of dextroamphetamine brand names in the US, from Dexedrine Spansule to Zenzedi to ProCentra. Stay with me as I explain the difference between mixed amphetamine salts like Adderall and dextroamphetamine, D-amphetamine, finishing up with Xelstrym, the only dextroamphetamine formulation that you can only get in the brand name, and the only one with a transdermal delivery system. The most famous brand name dextroamphetamine, at least historically, is probably Dexedrine, which is still available in the United States in the brand name, but only the Dexedrine Spansule formulation. Other forms of the Dexedrine brand have been discontinued. The other currently available brand name dextroamphetamines in the United States as of 2025 are Zenzedi, ProCentra, and Xelstrym. By the way, all of the dextroamphetamines that I'm going to be talking about today, except Xelstrym, are available in generic forms, including the generic equivalent of the Spansule, dextroamphetamine sulfate extended release capsules. Spansule, as the name implies, is a sustained release formula. What are amphetamines, and what's special about dextroamphetamine? Amphetamines are, of course, stimulants, the mechanism of action of which is to increase the neurotransmitters dopamine and norepinephrine, and to a lesser extent serotonin, by increasing their concentration at the synapse, the gap between neurons where communication takes place. Amphetamines do this by facilitating the release of these molecules from presynaptic neurons and blocking their reuptake by the very same neurons that released them, the presynaptic neuron. That is, they're dopamine norepinephrine reuptake inhibitors. This intensifies and prolongs the action of these chemical messengers. Enhancing the action of dopamine and norepinephrine in the dorsolateral prefrontal cortex improves attention, concentration, executive dysfunction, and wakefulness. Enhancement of dopamine in the basal ganglia may theoretically decrease hyperactivity. And enhancement of dopamine and norepinephrine in other brain regions, such as the medial prefrontal cortex and the hypothalamus, may improve depressive symptoms as well as fatigue and sleepiness not associated with clinical depression. Medications that increase the actions of norepinephrine and dopamine are also nice antidotes to antidepressant-induced lethargy, fatigue, and diurnal hypersomnolence, including the non-stimulant Wellbutrin, bupropion, which is also a dopamine norepinephrine reuptake inhibitor and an antidepressant in its own right. It's a nice add-on when patients are tired and sleepy because of their other medications. In the treatment of ADD, one hypothesis is that amphetamines rebalance the, quote, signal-to-noise ratio of cortical neurons. Norepinephrine theoretically enhances focus on important signals, the task at hand, and dopamine, in theory, reducing awareness of background activity, the noise. So one neurotransmitter is thought to be especially helpful for promoting concentration, and the other is theoretically useful in reducing distractibility. Keep in mind these are hypotheses. The reality is probably more complex. So amphetamine stimulants increase the actions of norepinephrine and dopamine, especially dopamine. Amphetamines are particularly dopaminergic when we compare them to similar medications. D-amphetamine, dextroamphetamine, is the right-handed stereoisomer, optical isomer of the amphetamine molecule, while levoamphetamine is the left-handed enantiomer. I'm not going to get into the specifics of the chiroptical properties of molecules here, but for a quick primer on stereochemistry and enantiomers, please check out my 9-minute video on the astonishing behavior of twin molecules. Basically, we're talking about a molecule and its mirror image, which is actually a different molecule in nature. They're not the same molecule, even though they're identical in terms of the number of atoms and the chemical formula, mass, and physical properties. Nature can nonetheless tell them apart. In 4-dimensional space-time, they interact differently with the body, which can also distinguish between left and right. Just like you can't put a right-handed glove on your left hand or your left shoe on your right foot, these molecules are identical in every way, but they're mirror images of one another. Some mirror images are superimposable, but a chiral molecule is a molecule that is non-superimposable on its mirror image. It cannot be perfectly aligned with its twin. This is true of the amphetamine molecule. Amphetamines have stereochemistry. We can tell the right from the left. So we have two versions, Dextro and Levo, right and left. Adderall is probably the most famous stimulant nowadays, and it's known as mixed amphetamine salts, a combination of 4 different amphetamine salts, 2 dextro salts and 2 amphetamine salts that are racemic mixtures. Racemic means that the mixture contains equal amounts of the 2 enantiomers, the D isomer and the L isomer. in a 1-to-1 ratio. It's an interestingly complex recipe, but all told, Adderall has an overall dextro to levo ratio of 3-to-1. Here's what's important. The body's norepinephrine transporters and dopamine transporters can tell the difference between the D and L stereoisomers. They interact differently with them. While both molecules are active at the receptors, the dextro version is more potent. Dextroamphetamine is about 4 times more potent than levoamphetamine at causing the release of dopamine, while levoamphetamine is more potent at facilitating the release of norepinephrine, noradrenaline. Also, levoamphetamine is less potent at inhibiting dopamine reuptake, so overall it's less dopaminergic. The significance of a racemic mixture is that because the weaker L isomer competes with its more potent twin at the receptors, preventing the dextro from binding whatever receptors the levo attaches to, if we remove it, if we don't have the L around, we get more bang for our buck. It's the same thing that happens when we isolate Lexapro, escitalopram, from the racemic citalopram, Celexa. In that case, only the L isomer is active. Dexedrine, because it's pure dextroamphetamine, would be expected to be more potent on a milligram-to-milligram basis than Adderall, which is mostly dextro, but a quarter levo. That's why a lot of patients prefer Dexedrine to Adderall, or Vyvanse to Adderall XR, because Vyvanse, a prodrug, lisdexamfetamine, is converted by the body exclusively to 100% dextroamphetamine. I released a video last year, What is it about Vyvanse? I've never gotten a negative review switching a patient from Adderall to Vyvanse, including immediate release Adderall. Frequently, I get a thumbs down in attempting to switch from an immediate acting preparation to a sustained release formulation. Patients don't like that a lot of times. The medication doesn't feel as strong. It doesn't feel as effective, even innocently enough for patients that aren't chasing euphoria. Immediate release preparations are easier to abuse for sure because you get all of the dose over a very short period. But I've never had a patient tell me that Vyvanse didn't work as well as any preparation of Adderall, including immediate release tablets. And the reason, undoubtedly, is that Vyvanse metabolizes exclusively into dextroamphetamine and the amino acid L-lysine. Here again, L standing for the left-handed molecule. But that's why. That's the deal with Vyvanse, as one viewer correctly discerned. And now I'm not going to talk about methamphetamine in this video, meth, but adding an extra methyl group on the nitrogen atom helps the molecule cross the blood-brain barrier more easily, further increasing potency. And there is an FDA-approved methamphetamine hydrochloride, which goes by the brand name Desoxyn, also available in generic form, and approved for the treatment of ADD and narcolepsy. Dextroamphetamine is not commercially available. However, it is present in racemic Desoxyn. So let me rewind here a little bit. The first amphetamine pharmaceutical was Benzedrine, marketed in 1932 as a, believe it or not, over-the-counter inhaler for nasal congestion. But 5 years later, Dexedrine, the more potent D isomer, was synthesized and marketed. So it dates back to 1937, but the drug became really popular in the 1950s and 60s when there was a peak in the widespread use of amphetamines in what, in retrospect, is considered the first major amphetamine epidemic in the United States, peaking around 1969. Dextroamphetamine was used as a diet pill and to treat narcolepsy and fatigue. But it wasn't until 1976 that the FDA reviewed a specific formulation under modern efficacy and safety standards, updated standards, the Dexedrine Spansule, and approved it for the treatment of narcolepsy and what was then called hyperkinetic disorder of childhood, aka ADHD. 48 years later, it must still be selling well because it's the only Dexedrine brand that's still available in the US. This approval by the FDA resulted in a boost to Dexedrine Spansule's popularity as a prescription medication, not surprisingly, that really took off in the 1980s onward. The Spansule, you will recall, is a controlled release formulation, an extended or sustained release formula. Each capsule contains small beads, half of which have an immediate release coating and the other 50% of which have a delayed release coat, resulting in a biphasic release, providing an initial dose promptly followed by the rest of the medication delivered over several hours if the beads aren't crushed. This can eliminate the need for lunchtime doses, which obviates the need to visit the school nurse every day. The capsules can be opened and the beads sprinkled on a small amount of applesauce or yogurt if the patient has trouble swallowing capsules, so that's another advantage. But the beads mustn't be crushed. It's important to instruct young children not to chew the beads, and it's important to ensure that the entire dose gets administered. But that can be done at breakfast, before school, and we're good for the day. Other dextroamphetamine brands that are still around include Zenzedi, immediate-release dextroamphetamine sulfate. Because Zenzedi is immediate acting, it usually has to be dosed multiple times a day, so it's less convenient. Like Dexedrine Spansule, Zenzedi is FDA approved for narcolepsy in children and adults ages 6 and older. However, the medications differ in their FDA approval for ADHD. Both are approved in adults, but whereas the Spansules are approved in children ages 6 to 16, Zenzedi is approved in children as young as ages 3 to 16. It's not known if Zenzedi is safe and effective in children under 3 years of age because infants and toddlers weren't included in the study as cohorts. I'm not a child psychiatrist, but I think it would be pretty insane to give a 2-year-old dextroamphetamine for any reason. Similarly, the Spansules have not been tested in children younger than 6 years. Now this begs the question, what about 17-year-olds? Both medications are certainly used in 17-year-olds, which technically would be off-label, meaning without explicit FDA approval. But physicians are certainly free to prescribe off-label according to their best medical judgment. FDA approval doesn't dictate treatment, nor supersede a clinician's judgment. Although from a medical legal standpoint, having to prescribe something off-label can have a chilling effect on a prescriber's willingness to do so, especially in the treatment of children. So for example, a 5-year-old in need of a long-acting preparation, a clinician could certainly and reasonably prescribe Dexedrine Spansule. That wouldn't violate the standard of care, in my opinion. But if something went wrong, even if it had nothing to do with the formulation, it might expose that clinician to greater medical legal risk because the clinician went out on a limb a little bit. It's not that the FDA is saying that the medication is not safe and effective for younger children, it just hasn't been studied. ProCentra is also immediate-acting dextroamphetamine sulfate, likewise approved for ADHD in children ages 3 to 16 as well as adults, but it's a colorless, bubblegum-flavored oral solution for kids who have trouble swallowing pills or for those who require precise dosing. One advantage is that we can use just exactly the amount of milligrams that works best. And I guess that might be one reason to use this bubblegum-flavored liquid in an adult. It's also approved for narcolepsy in patients ages 6 and older. And finally, in terms of brand name dextroamphetamine, we have Xelstrym. Now, again, there are many generic preparations of dextroamphetamine. I've listed the remaining brand names in the US as of this posting, and all of them up to this point have generic counterparts, but Xelstrym is not available in generic form. It's brand name only. It's the only dextroamphetamine product that is exclusively brand name, and it's approved for ADHD in ages 6 and older. Unlike Zenzedi, ProCentra, and Dexedrine Spansule, Xelstrym is not FDA approved for narcolepsy, so that's another major difference. But what really makes Xelstrym special is that it's the first and only amphetamine treatment for ADHD that uses patch technology to passively deliver medication through the skin, transdermal patches. They're available in 4.5, 9, 13.5, and 18 milligram strengths, delivered over a 9-hour period. We start with the 4.5 milligram strength, and instructions are to increase by 4.5 milligrams each week, with the maximum recommended dose being 18 milligrams over 9 hours. It should be applied 2 hours before an effect is needed, removed within 9 hours, and the site of application changed each day to minimize the risk of skin reactions. The patch can be applied to the hip, upper arm, chest, upper back, or flank. Blood pressure needs to be monitored regularly. Current recommendations from the American Heart Association are that it's not mandatory to obtain an electrocardiogram, ECG, prior to prescribing a stimulant to a child, but it's reasonable to do so. However, the American Academy of Pediatrics does not recommend an EKG prior to starting a stimulant for most children. Obviously, this would depend on the child and would be different for children with pre-existing heart conditions. In children, we need to monitor height and weight. Height can be stunted by stimulant medications, although this is controversial. I'll talk about that in a second. And weight loss due to anorexia is not uncommon. A word on so-called drug holidays. Drug holidays, periods during which we temporarily suspend treatment with these medications, were originally recommended in an attempt to avoid the possibility of stunting height. Now, however, most studies have shown that parental height, i.e. genetics, is what determines a patient's final height, and that most children and adolescents taking stimulants chronically do eventually reach their expected height, perhaps more slowly than their counterparts. So what we see in some kids is a decreased height velocity, but eventually they get there. Still, we should enact drug holidays whenever feasible, such as over summer break, to compensate for any growth suppression during the school year, or even over long weekends when there's not a lot of homework or studying to be done and there's no hyperactivity to contend with. It's always a good idea to make a reassessment each year before reinstating stimulant therapy for the succeeding school term. I do want to note, however, for adolescents, studies have shown that those with ADHD who drive without their medication are much more likely to get into an accident. And also the severity of those fender benders tends to be much greater than we would anticipate. There are also social benefits to consider, not just academic. So the decision to enact drug holidays should be made on a case-by-case basis based on a careful risk-benefit analysis. Other side effects: anorexia is common and weight loss is possible. Nausea, headache, and abdominal pain, non-specific possibilities common to a lot of medications, especially in children. Insomnia is also particularly common with stimulants, not surprisingly, and so the medication should be administered early in the day, especially extended-release preparations. Insomnia can actually, seemingly paradoxically, improve with additional late-day doses of a short-acting stimulant. When stimulants wear off, there's often a transient rebound sleepiness that's actually conducive to falling asleep. Patients may not sleep as well, sleep architecture is disrupted, and there may be middle or terminal insomnia where patients wake up frequently throughout the night or can't get back to sleep, but initial insomnia is often not a complaint unless we dose too close to bedtime. With my adults, I frequently use this combination strategy of an extended release preparation in the morning, followed by as-needed immediate release booster doses in the early afternoons for those patients who need them, to power through and to avoid that sluggishness or sleepiness they might feel after lunch. And that works really well. It gives the patient greater control over dosing and over their symptoms, and they get to sleep just fine, most of them. And so that can actually be a treatment for stimulant-induced insomnia, adding low doses of an IR preparation in the afternoons. Stimulants also exacerbate tics in patients who are susceptible. Tourette's disorder is one contraindication. And stimulants can cause tremor and dizziness, and not infrequently irritability and anxiety, again, in certain vulnerable patient populations. Medication-induced irritability is more common with amphetamine-based stimulants compared to methylphenidate. Methylphenidate, not methamphetamine. I'm talking about Ritalin here, or Focalin, Concerta, Metadate, and others. If you want a deep dive into the more serious potential side effects of stimulant therapy, please check out my Risks of Stimulant Therapy Instant Replay, a 4-minute excerpt from my long-form Vyvanse video. Finally, other off-label uses in adults include for treatment-resistant major depression, often as an augmentation strategy added on to an existing antidepressant medication regimen, and to treat amotivational or lethargic states in the elderly with dementia. I've also used it with some success to sharpen cognition in that population. And I've also used it frequently to treat pathological procrastination in adults. Please see my fascinating video on that. And don't forget to check out my Astonishing Twin Molecules video. Thank you for listening. As always, questions and comments are welcome.